Thanks to David, because he was clever enough to apply to for a reference center of rare disease where psychiatrists were not very trained in the first ID, and it was very difficult. And so I start working in this field, and I start to see many patients, and some of them with psychiatric signs, all of them with psychiatric signs, but some of them with organic disorder. And the idea was that there are so many patients in psychiatry that it is very difficult to see and to detect and to have an idea and to think about an organic disorder in some of them because it's not so frequent. But also, we know that psychiatric patients, especially schizophrenic patients and autistic patients, have a lower life expectancy. And so it's very important, and most of the time they lose in life, it's related to organic condition. Sometimes when they are elderly, it's acute organic condition, but also it can be a chronic organic condition, and that's what we are going to talk about. So thanks really for the organization, for Boris, David, Marie-Odile, Claudine, and Francisca, to let me talk about that. I have some conflict of interest. I say it quickly, but it's important because of this work. We are going to talk about what we can call psychosis, which is more larger than schizophrenia alone. As you know, it can encompass schizophreniform disorder, schizoaffective disorder, and somehow bipolar disorder, and it's a huge prevalence of 3.5% for some authors, especially even us. We have in schizophrenia, for example, many organic conditions that might be associated. Here are just a few of them, but it's a lot, and it's very difficult to know everything. And sometimes it's also difficult to know if these conditions are really related to schizophrenia or just hazardous. But we know that, and when we are, because I was especially involved in the last decade in inborn error of metabolism, and you go a little bit into the detail, you may find a lot of disease of neurometabolic and endocrine disorder that might be associated with schizophrenia. So it's not only talking about or searching for few disease, it's many, many, many disease, and it's very complicated to make the diagnosis. Sometimes it's very tricky diagnose, and sometimes the examination, and we talk about the cost of all the blood samples we have to analyze, it's very expensive, and so we cannot do it for all the patients. So the question is, how many of these patients may have what we can call organic psychosis? I don't go into detail of what is organic psychosis compared to psychosis because it can be complicated, and we all know that it's a kind of continuum, but we can talk of that later. For simplicity of the talk, I just talk about organic psychosis like that, and we don't know if it is a lot of patients or it is just few patients. We only have ID in very small sample of patients, especially because I'm a child psychiatrist, when we are interested in early onset schizophrenia, which was obviously very much, we have a lot of exploration of this patient with an extensive examination, and we found more or less 20, sometimes 25% of patients having some organic disease associated with this early onset schizophrenia. But it's only a very small part of patients with schizophrenia, but we don't know for all patients. All of you know that 22q11 microdeletion patient might be found in schizophrenia for 2, maybe 4% for the youngest, but that's all we know. We don't have knowledge of everything. So the main question and the main topic of this talk is how to detect them with accuracy. there is a long history about what we can call psychosis clinical atypical features, but the literature is very scarce. There are few case series, there are few studies which were not very conclusive. It was very difficult, and at the end of the day, what we have is what we all know because we saw it in so many textbooks of psychiatry or things like that. And I just give you an example. Is about empirical findings. What we know is when there is a confusion, for example, in a patient with schizophrenia, you must think about organicity. When there is some visual hallucination, maybe more important, you must think about organicity and think like that. We know this kind of thing, but it's only empirical work because it was so difficult to have a large series of patients with organic disorder and the other one with no organic disorder to make comparison. With a group of colleagues, we work very much, and we didn't invent anything. We just encompass things and have talked with many people in many places to find what we can call atypical features in psychiatry, in schizophrenia especially, and we found 22 of them at the beginning. And you can find here at a place when there is a treatment resistance to antipsychotic or unusual side effect, what we were talking about. And so, of course, we also took the visual hallucination that we were everywhere, the mental confusion, catatonia, because it's known for catatonia, the progressive cognitive decline. I go very fast because it's not the main point here. Intellectual disability, when it's associated with schizophrenia, can be a question. The presence of psychiatric symptoms in medical history, we will see it's very important. The treatment resistance, and some other signs, and especially if you can find some visceral signs in the patients. So we had this criteria, but it was not very useful because it was just criteria like that. We can just trigger us the idea to go further in the search for organic disorder, but we didn't have any cutoff, we didn't have anything, so it was not very useful in clinical practice. And in clinical practice, you may imagine, because it was very interesting to have a session about psychiatry with a lot of clinical example, because psychiatry is a craft. It's only clinical. You work with patients, and it's very difficult to make distinctions between patients. So it was very difficult. It's very difficult for practitioners when they see a lot of patients to say, okay, this one needs further exploration and this one not. And it's very hard to say. So how to turn these criteria, these atypical psychiatric features, into a kind of suspicion index? We use a method that is used for many years now in different fields of medicine, but it's also used now a little bit more, maybe since 3-4 years. I saw a lot of literature, more than 1,000 articles about this Delphi method, which is a method based on expert judgment. It's very useful when you have very few data, and the method it needs to refine eliciting expert judgment to obtain a kind of consensus more than direct inclusion of patient. It's about what is your judgment about a disease and what you will find in it. So we use these features that I already present you, and we decide to have a quotation, a scoring about in 1, 2, 3, 4 level for each of the item. One was absent. The item is not present in the patient. The patient doesn't have anything of that. One is slight level, because it's present, but it's very low intensity. One is high intensity, and one is very important, is a prominent part. It's the most important feature you can find in the patient. And it's usually like that, to have one kind of sign, one kind of atypical sign that is the main sign for the patient in the clinical part. In a Delphi method, you need to find experts. It is a very difficult part because it's a human part. You have to ask people to work for, it's very complicated because you have to ask them questions about patients, their expert. It's kind of brain freed. We need them to really think for a long time, and so it's kind of difficult. So we find 12 experts in 6 countries and 3 continents, and we'll show you the list after. And instruction was very simple. Please think about 10 patients with schizophrenia and 10 patients with organic psychosis. Just think of them. And complete how many of them, according to your experience, just your experience, your expertise, show no slight, evident, or prominent symptoms. If you think about 10, you will have, for the list, maybe say for one sign, maybe visual hallucination more important than other kind or other type of hallucination. You will have, I don't know, maybe 6 patients with prominent sign, maybe 1 with, I don't know, and you do it for all the items. So it's quite a long work. So we make round in Delphi, meaning that we have the answer of the expert, then we analyze them, then we go back to the expert, then we analyze the answer, then we go back to the expert, and so on. So what is difficult is to know how to stop, because if you do too many rounds, at the end, the experts are bored and they don't answer anymore. That's really like that it works. After round 1, few experts, many experts, suggest that we could add 2 items, which were very not so psychiatric oriented clinical signs about autosomic dysfunction, especially for autoantibody encephalitis. That was important, and also EEG measure with some specificities. So we add, after round number 1, we add these 2 items. So after round number 3, we noticed that it was not, we had no big difference between experts, with expert answer, and so we reached a kind of consensus, and also that if we go further in round number 4, we will have no difference in the answer, but maybe we can lose experts. So we stop there. We had 4 levels of responses. So usually when you do Delphi method, there are many articles. It's very complicated. It's just yes or no. It's very much used when you need classification for, sometimes in cancerology, they use it very much because there are very few patients sometimes, and so you don't have many data, but you have sometimes very good experts. So you can ask, and they ask, the sign is there, sign is not there, and it's very useful for classification of stage 1, stage 2, stage 3, stage 4, things like that. But here we have 4 kind of level of response, so we needed to change it and to translate it into a final score. So we use different technique, we think about that, and so at the end, we think that absent was 1, slightly was 2, evident was 3, and prominent was 4, which was simple, and we divided by 10. The resulting value was, of course, something between 1 and 4, and I will show you, and we try to have round, since we achieve a 75% of consensus between experts, which means that, so we have all the results here, which is not very interesting, but it's just to see that it's a lot of numbers at the end. And so we also add the way to analyze the difference for each of the items between psychosis and organic psychosis for each of the item when it's encompassed between all experts. We also find, curiously, that 2 items here, the presence of psychiatric symptoms in medical history and psychiatric disease in first-degree family, which is more or less kind of something in not similar but in the same vein, are not working in the same way, meaning that for these symptoms, when they are present, there is less possibility for the expert to have organic psychosis than to have not non-organic psychosis. In the other, it was in the same way. If the item is present, if there is more possibility to have organic psychosis than non-organic psychosis. Reaching the consensus was obtained for most of the items, but not all of them. Here you can see in blue the consensus when it was not obtained. And what you have in the square is 75% of the answers. And when you have more than 3 points outside of the box, meaning that it's not reached. And so you will have here not reached for mental confusion, and you can see and you can read it in blue. And of course, we did the same for organic psychosis, and the consensus was reached in most of the items, but not all of them. And also here we have 6 with not total consensus, which is not totally crazy, because it's a very tricky and very small expertise, and so we could think about it before that it would be difficult to have total consensus. So after the question was, we need to add a weight for each of the items. Sure, if we have 24 items, some of them are more important than others. Some of them maybe can be more relevant than others. So we need to add weight. So we use several methods to work about weight. First one was very simple, what's called the absolute difference. So we made the difference between, for each expert, between the scoring in organic psychosis and non-organic psychosis. So we had scores, like you can see here, it's an example for visual hallucination. Second, what we made is linearized difference. It's not so different, but we plot the absolute difference in a linear regression line, and so we just see where it was on the line. So it's not so different, but it's another way to do it. Third one is the ratio difference. Ratio difference is not so different. So if you make just the difference between, for example, and see here on red, between also for organic, for visual hallucination, you make the difference between what experts are scoring for organic condition and non-organic condition. Just a simple difference. It was the difference, the first one, the absolute difference. And you have a score, it's 0.38, for example. Here we made a ratio, which is 175 divided by 133, and so we have another number. And it's more important because it gives more important number when you are outside of the main numbers. It's more easy, and it will enhance the small value, and so it's also important because of the distribution of the scores. So at the end we have a large table with all the difference, and we use a third, last way to do it. It's arbitrary distribution of arbitrary calculation, meaning that we decide to choose 3 levels of weights which were arbitrarily established for absent, slight, evident, and prominent. So if the scores, the 4 scoring were low, we use 0, 0, 1, 2 for absent, slightly, evident, and prominent. If the score were middle, we use 0, 0, 2, 4. And if the score was very important, we use 0, 0, 4, 8. So at the end, we had this kind of arbitrary weight table showing the different weight for different scoring of each of the items. As you can see, for item 9 or item 19, we had to invert the scoring because the scores are not going in the way we thought at the beginning it should go. So we have to invert it, which is obvious. At the next step, and the final step, we tried to have a real patient study. That's always a point, and it was quite difficult. So we did something very simple, which can be discussed. We asked the same expert not to score about real patients they have, because they are experts in this field. They have patients like that, so they may score real patients. So it's not just think about a patient. So think about patients in general. It's think about one specific patient. So some experts have 10 patients, some experts have less than 10 patients, and so we tried to reach something like 200 patients, 100 with organic schizophrenia, 100 with non-organic schizophrenia psychosis. When we did the scoring at the end, we dispatched them on a distribution score like that, and so we find that there are, of course, obviously, different scorings, this type of scoring, suspicion index score, for each of the patients with organic or non-organic schizophrenia. If you make the distribution frequency on an histogram, you find also, and it's quite evident, that it's, the distribution is different between patients with organic schizophrenia and non-organic schizophrenia, about the 198 patients we had. So at the end, we tried to find a threshold of score for suspicion, for low suspicion, medium suspicion, high suspicion, and very high suspicion. How we did that? We did, and we tried to find what was the sensibility and the specificity of our scoring. So we find a very high specificity for organic psychosis, very likely to detect organic patients, but also a medium sensitivity, which is normal, for organic psychosis, that we might miss some of them. But it's quite important to be sure that our score is very good, and if it's very high, we are quite sure patient may have some organic condition associated with the psychosis, because we are going to engage a lot of, I don't know, work and maybe cost in this patient. So it was our argument. When we see and we make the calculation of weight with the 4 methods I present to you, absolute difference, linear difference, ratio, and arbitrary weight, and so we found that there is no big difference between the 4 ways of calculation, so it was quite easy to decide the low, moderate, high, and very high suspicion for patients. So at the end, what do we have? It's not perfect, but at least it's done. We have the 24 atypical psychosis item, all of them, with scoring, with 1, 2, 3 scoring, because we noticed that it was not discriminant to have the slight column. It doesn't change anything. So we did the scoring like with absent, evident, and prominent. At the end, you just have, it's a simple, the idea is to have it like a simple paper sheet you can use in your desk. It's for clinical practice. It's not, it could be used for research, of course, but it's not, it's made for clinical practice of people that see many, many patients. So it has to be quick, it has to be relevant, it has to be sure that if you go and ask to many people, do you want to see my patient, make examination, make a blood sample, make a lumbar puncture, or things like that, at least you are very likely to find something, because we know that in clinical practice it's very difficult. That's a real life. At the end, you just add with a total, and with your total, you know, if you are over 5, you have a low probability. Over 8, you have a medium probability. Over 10, you have a high probability. Over 16, you have a very high probability to have such patients. Of course, we have limitation in his work, and you all understand that. The number of experts was quite difficult. Generally in Delphi method, but you have everything. You have Delphi with 5, Delphi with 50, not more than 50. It's very rare. It's between 15 and 20 experts. We didn't have absolute consensus. which is also quite classical in Delphi, but we have to notice it. We use the same group for Delphi and real patient because it was convenient, of course, but we could do differently. Obviously, it's an idea to go further, or to make further study in this domain. We didn't test it in large sample and real practice. And more generally, and maybe to open a little bit discussion about this subject, we know that it's very difficult to make distinction between what is organic psychosis and what is non-organic psychosis. Especially, we don't know if there is at least non-organic at all psychosis. Maybe we can know the weight of organic disorder, exactly like Thomas Bourgeon showed us this morning with the orchestra, something like that. And we know that some people are more important in the orchestra, and we know that some organic dysfunction are more important in the final phenotype, I can say like that. And so it's also important. This work is only, and it's like that, it's only clinical work, and that's the use of it. And I want to thank the experts involved. You can recognize David, all of them from different countries, and I thank you for your attention.